Welcome to our webinar. I'm Lisa Washburn. I'm Associate Professor and Community Health Specialist with the University of Tennessee Extension. This webinar is part of a series addressing opioid misuse in Tennessee. Today's session is Words Matter, how we talk about substance use and addiction. And it's brought to you through a partnership between the University of Tennessee Extension and East Tennessee State University's Addiction Science Center. This webinar is part of a USDA-funded project preventing rural opioid misuse through partnerships and training in Tennessee, or Prompt Tennessee for short. The Zoom webinar format is used for today's session, so your mics are automatically muted. Feel free to drop any questions or comments into the Q&A or chat, and if you'd like to speak, use the raise hand function and I'll unmute you. We'll have time at the end of our session today for questions. I'm really pleased to introduce our speaker today, Dr. Meredith Ginley. Dr. Ginley comes to us from East Tennessee State University, where she is an assistant professor of psychology and a licensed clinical psychologist. She completed her graduate training at the University of Memphis, her internship at University of Mississippi School of Medicine, and a postdoctoral fellowship in addiction at University of Connecticut School of Medicine. Dr. Ginley is interested in improving treatment outcomes for individuals with behavioral and substance use addictions. Today, she'll help us take a look at language and how our words, the terminology that we use, can help support individuals and families in recovery. So thank you, Dr. Ginley, for being with us today.
Thank you so much for inviting me to talk. I'm going to get my slides set up just with me a second. Okay, so thank you so much. So I'm going to talk today about language and the words that we use around substance use and addiction. So one of the roles I have now, in addition to my research and my clinical work, is that I currently teach doctoral students how to treat persons with substance use disorder. And so a lot of what I was thinking about when I was putting together this talk was some of the ideas that I try to convey to them in my classes. And I have no conflicts of interest to disclose. All right, so our objectives for today are to go over some background on stigmatizing language use related to substance use, to recognize some of the stigmatizing assumptions related to persons with substance use disorders, and then also to review some steps that we can take to reduce some of that use of stigmatizing language. And throughout the talk, and then a bit more specifically and explicitly at the end, I'm going to share some examples of stigmatizing language and some alternative options that we can try and try to make more use of. All right. So stigmatizing language around addiction is quite prominent in our culture, and even if you were to look at kind of at the world of people who specifically are providing treatment to persons with substance use disorder, we tend to use a lot of the stigmatizing language kind of within our profession. And if you take just a few seconds to either drop down or you can drop some words in the chat, think of things that come to mind when you think of a person with addiction. Or you can think of maybe not things that you personally think of, but maybe what do you think society thinks of when they think of a person with an addiction. And I'll pause and I'll give you a few seconds to think.
So some of the things that we're seeing pop up are a lack of self-control, unemployed. Thanks for those responses.
Yeah, thanks for those responses. So I do this with my students on the first day of class, and I usually set this exercise up a bit more. I just gave you guys the free open-ended, but usually with them, I try to think of some of the worst. I tell them to think of some of the worst things they've heard, and then try to. I do this to try to make them be a bit more comfortable with self-examining themselves and kind of letting them know that it's okay to think of some of the worst things we've heard, because we're in a place where we're trying to learn and do better. And that critical examination is key to that. We also, we're not going to think of anything that's like so creatively stigmatizing that a person with substance use disorder probably hasn't already heard it themselves or maybe said it to themselves. And we can usually come up with a pretty long list. So yeah, things like junkie, addict, alcoholic, abuser, medication-assisted treatment is one, dirty urine, clean urine, remission, relapse, calling a person a sinner, a person broken, in denial, heading towards rock bottom, drifters I see in the chat, that's another good one. And some of these words are, they're just, to use a really super scientific term here, they're just mean. They're just mean words. And they convey criticism, hostility, disrespect. But others of these don't really rise to that level of being like explicitly mean, but they're instead, they're not helpful. And not being helpful is a problem when we're in a position where we're trying to help. And as I mentioned, talking about my students, this stigmatizing language, it's not anything new for the persons with the substance use disorder. I can pretty much guarantee that they've said all of these things to themselves in their own head, or they've had someone else say it to them beforehand. And kind of because that's become their internal script, it's part of the reason why it's so important and so meaningful for us to change the words that we use, because words have so much power. And changing how we speak could help change that internal script, change how they see themselves, maybe think that there's more opening for change, more insight into why they're doing the behavior that they are, or maybe just have a bit more hope. So it's kind of a great reason to kind of aspire to some change. All right, so why do we just have so many stigmatizing words related to addiction in the English language? And we have a pretty complicated history with addiction here, and addiction type behaviors. And there's lots and lots of reasons why the language around substance use is so marginalized. But just a few components I wanted to highlight was, if you think just about alcohol use, so alcohol, which you can go pick up at the grocery store, is 100% legal, very socially acceptable to use. And even with that drug, we have a very complicated history where there's been times within our US culture where it was illegal to have alcohol or to possess alcohol. And there was incredibly stigmatizing things thought about persons who are using even just a little bit of alcohol. And even I think about like the Bible, and the Bible has a pretty complicated relationship with substances, right? There's multiple references to the dangers of excess, but then there's also a lot of times where the water gets turned into wine. So it's a mixed message in some ways, makes it a little bit confusing. Professional and medical type texts, we don't do any better. The language used by care providers also has historically been explicitly stigmatizing. For example, just the word abuse. So like abuse of X drug, abuse of marijuana, that's language we're trying to move away from. But up until 2013, that was the diagnosis that a person had to get in order to bill for treatment and get their insurance to pay for treatment. So we've been using that term as part of our diagnostic code. And right now, the government organization that provides much of the funding for substance use treatment is called the National Institute on Drug Abuse. So it's right there in the title for that national body. Policy has also historically focused on this idea of kind of building up drugs as bad, and possession of drugs isn't seen as a health concern, but as a legal concern, concern that necessitates jail time, not treatment. That definitely influences how we interact with persons that are in possession of drugs. There's also several assumptions about substance use disorders that influence the language the language we use about illness and their treatment. And these kind of assumptions are likely influenced by this historical context. So the first assumption I want to highlight is this idea that persons with substance use disorder are particularly ambivalent about change or resistant to change, and that there's some resistance or problem with persons with substance use disorder changing that's kind of above and beyond just humans not wanting to change. There's a lot of language that will come up here, about that a person's in denial about wanting to change. They're in denial about their problems. And the reality is that this is human nature. Humans don't like change. And particularly health changes can be hard. So you think about, like, you might make a goal of not eating so much sugar, and then you decide, I'm gonna wait to change my goal for sugar until after Christmas. Or you stop eating sugar for a while, and then you decide, like, actually, I kind of like cookies. I'm gonna add cookies back in to the mix. And that's how we work. That's kind of our process. And that we make some sort of idea that persons with substance use disorder shouldn't be allowed to have kind of this natural human change process the rest of us has is stigmatizing. We also don't know why persons might not be ready to change. It could be that they're interested, but their family members want them to keep using. There's kind of something in that family system that's maintaining. It could also be that they've tried to change, they've gone to treatment, they've started taking medication, and it's not working for them. They're having side effects. Their treatment provider isn't competent. They don't like them. That's making it hard for them to engage in steps of change. And it could also be something about needs not getting met. So perhaps they have a significant amount of anxiety, and they are, when they stop using the drug that they've been using, their anxiety gets even more intense. And they just don't know how to function within their anxiety without that drug present. So it might not be that they don't want to change, it's that they just can't figure out how to live with that much anxiety. Another stigmatizing assumption is this idea that treatment is always necessary. And this is a little bit of a different one to hear. So, because we always are trying to encourage people to go to treatment. But statistically, there's actually a good amount of people that make changes in their substance use without engaging in a formal treatment. And there's some variation here. So persons with, say, an alcohol use disorder or gambling disorder, they might be more successful in engaging in recovery on their own, whereas a person with an opioid use disorder might be more likely to require formal treatment. But in general, kind of what the process of recovery looks like is the person usually realizes that they're not living the life that they want to. This drug just doesn't fit in, and they don't want to be like that anymore, and they start to change. They decide to change, and this process can sometimes we can be helpful as individuals. We can be helpful in helping them identify reasons to keep that change, make that change, help them remain accountable to the changes that they want to make, check in with them, encouraging them to do activities that are in line with their recovery. But we don't have to say like, oh, like, you can't get better without treatment, because some people can get better without treatment. It's also important to remember that treatment doesn't work for everybody all the time. So sometimes a person can engage fully in, say, an inpatient treatment course, 28 days, and they come out and they haven't changed their substance use. And that's not a failure of the person, that's a failure of the treatment. We need to find another treatment that would work for them. And then the third assumption I wanted to bring up was this idea that the only way to recover from substance use disorder is abstinence, that that's the only path forward. And many treatment programs are kind of built around this idea. A lot of our stigmatizing language is built around this. So talking about relapse or falling off the wagon, where any return to use is a failure, as opposed to kind of thinking about the cyclical nature of addiction, where there tends to be a natural course where persons return to use periodically throughout the course of their recovery. And they maybe will be not using as much as they were prior to when they started their path to recovery. They were using in a safer manner. We also want to have space for patients to kind of be experts in their own recovery and make alternative treatment goals, such as reduction. I don't know if people saw, there was some press recently, Demi Lovato came out as California sober, and the definition of this was they don't use pills, but you still drink and smoke pot. And that got a good bit of press. A lot of the press was like, this isn't recovery, this isn't, this person still has a substance use disorder, but perhaps that works for them. Like, who are we to judge if that's how they're maintaining their health and they're doing that under the care of their doctors and their providers. Another place where the abstinence only assumption is risky is particularly related to medication assisted treatment, because a lot of the medications can be seen as kind of not a person not being fully abstinent, and then they're seen as persons on those medications are treated negatively. And the metaphor kind of I always think of here is, we wouldn't treat a person that was taking medication for diabetes negatively in that manner. And similarly, continuing that diabetes metaphor, we don't expect a person with diabetes to achieve perfectly normal blood sugar for the rest of their lives, never have any elevations, never decide, I'm not going to have a piece of cake at this birthday party. We expect that kind of the course of that illness is that there's fluctuations in blood sugar, and that persons take medical action to correct and get back on track. So why do we see substance use differently? So what can we do? So in addition to kind of recognizing and thinking through some of those assumptions, you can also reflect back on some of those content you learned earlier sessions about neuroscience of addiction. We also have some specific examples of language swaps we can take. So one of the kind of the most straightforward ones is the use of recovery-oriented language. And this just often involves the use of the word recovery in whatever you're talking about. So related to persons with substance use. The other one that is kind of gaining traction not only in substance use research, world talk treatment, but across kind of treatment of all persons with health conditions, is using people first language. And what we do here is instead of the person kind of becoming their disorder, so an addict, a diabetic, a deaf person, we literally instead say person with substance use disorder, person with diabetes, person with hearing impairment. And we let their kind of personhood be the primary thing in your descriptor, and you kind of add in the thing that they're working on or the thing that they're struggling with afterwards. And then the final kind of strategy is to think of substance use as a health issue. So diabetes is one I always kind of hold in mind. Hypertension can be a good one. That's usually something people have some familiarity with kind of how that illness works. And so if it's something we wouldn't say to a person with hypertension, we should probably rethink why we're saying it to someone with a person with substance use. So like if you can imagine, you go to get your blood pressure taken at your doctor's appointment and the nurse says to you, this is a dirty blood pressure. Like, is that helpful? Probably not. And yet when someone with a substance use disorder takes a urine toxicology screen and there's the presence of the substance that is the thing that their health condition makes them use, we call them dirty. Why do we do that? All right, so here's some explicit examples. So instead of saying words like addict, junkie, druggie, we use that person first language. We say person with substance use disorder. Instead of saying an ex-addict, we use that recovery terms. We say person in recovery. The non-compliant, bombed out, treatment resistant, those type of words, we're just saying the person is choosing not to engage in treatment at this point, kind of recognizing their own personal autonomy. Relapse, we're going to say the person had a setback, the person had a lapse, had a return to use. And then one of the last ones is that idea of staying clean, which that's one of those ones where it's like not explicitly mean, but it's just not helpful, because if you kind of have clean in your mind, you've got the opposite of clean is dirty, and we don't really like calling people dirty. So we're going to, instead of referring to someone as staying clean, we're going to refer to them as maintaining their recovery. And if you have examples of things maybe you thought of when you were thinking of possibly stigmatizing terms that you're kind of trying to think of, how do I reframe this, you can feel free to drop that in the chat. And don't expect to be perfect about this. I know I personally mess up on this sometimes. I maybe have even said something not perfectly in the course of this talk, because a lot of this language is very much ingrained in our culture, and then even within our research. I think of that term relapse is something that's very standardly used in our research literature. And the majority of the things that I read on a day-to-day basis are going to use that word relapse. But then when I'm out kind of day-to-day life, talking to the community, talking to my students, talking to patients, I make sure I need to switch to that return to use language, because that's much more helpful to kind of capturing the course of the illness. So assumptions are, so kind of just general overall conclusions is kind of thinking through kind of our history and kind of that neuroscience you can think of that you remember from earlier talks. So there's kind of a basis for this. We're not surprised that stigmatizing language is incredibly present in our day in and day out. We also want to check our assumptions. So assumptions related to reminding ourselves that persons with substance use disorder can change just like anybody else. There's not something specifically inherent about these people that make them unable to change. Persons might not always need treatment. If they're able to make changes on their own, we should trust that change and be happy for them, encouraging them and supporting them in their own recovery. Individuals are the experts in their own recovery. Treatment programs may not work for everybody, and that's just means they need a different program, not that there's something inherently wrong with them. And then also this idea that recovery doesn't always have to be this perfect lifelong abstinence model. It could look a little bit different and people could still achieve health. In kind of changing our language, we're always wanting to put our focus on recovery, put our focus on health, and putting our focus on persons first, people first. And I think our idea is like, if our concern is that stigmatizing language is conveying criticism, is conveying disregard, disrespect, what we're kind of how we flip that is to be objective, to offer health first language that's full of hope as our antidote. So we make an effort to convey that hope, to think of recovery and change as possible, and not a finality with our words. And we can make an effort to make these changes in our stigmatizing labels at all levels. So it's not necessarily just when we're talking to persons with substance use. We can make a change in the language we use when we talk to our friends, when we talk to our families. We can push back on how the medical system treats individuals with substance use disorder, and then even policy level changes, thinking about the things that we're naming things, what we're calling, referring to people as, and the hope here that if the whole system that persons with substance use disorder comes in contact with is more full of hope and more focused on them as individuals, then they maybe will have more success in making change and sustaining change. We'll just have references. And that is the end of my talk. Thank you.
Thank you, Dr. Grimley. If folks have questions, feel free to drop them into the Q&A or into the chat. And while people are thinking about their questions, I do have one for you. We've made this shift from using the term addiction to substance use disorders or disorder. Can you give us a little bit of background on that shift and when it happened?
Yeah, so it's still sort of happening. It's not going to be universal. Like, you'll still definitely run into places where addiction is very much being used. I think I'm from the Addiction Science Center. That's very much a biological word related to substance use disorder. The shift was, I think, like the most official change would have been with the DSM-5 that was published in 2013, which is like kind of the official manual for diagnosing people with any sort of mental health condition that's used in the US and several other countries around the world. And it used to be that a person was diagnosed with, X, alcohol abuse, alcohol dependence, marijuana abuse, marijuana dependence. And we shifted in that new edition to use disorder, mild, moderate, or severe. And it's much more precise language. And then it also is modeling much more on the idea of kind of what the person, it's a person with an illness, as opposed to they've kind of, once you have this, you become just this. This is kind of your main identifier. And even that diabetes, diabetic was very much a term, and we don't use that as much anymore. Now we talk about people with diabetes. The idea being there's so much more to them than just the fact that they have this health condition.
It sounds really similar to the ways that we have started talking about disabilities, and that it is a person with a disability and not a disabled person. So that makes sense. Are there any other things that we should keep in mind in our day-to-day life in the language that we use? I liked how you shared that nobody's really perfect at it.
Yeah, no one's really perfect at it. I think this is aspirational. I think kind of our first step often is we start noticing it, like, oh, hey, like that building is named something, that office is called X addiction. Like, that's like, is that the way we want it to be? Why is the National Institute of Drug Abuse called that if we've stopped using trying to stop using the word drug abuse? Probably because it's on 8 million things, and I don't even know how much money it would cost to change the name. But that kind of, just noticing, I think probably is the first step, and then figuring out maybe what things you're comfortable with changing. And I will say, like, sometimes when I meet with people, like, they very much identify with certain words, like they refer to themselves as an addict, and that's a word that's helpful and useful for them. And again, that's kind of where I back into, like, a person's the expert in their own recovery. And if that word is useful for them, then I'm not going to say, like, no, we can't use that word. we can use whatever word's helpful to them. So it's not like these words have to go away forever. We're just trying to use what is maybe most helpful to most people. And you can have that conversation, like, you know, you like the word addict. I'm wondering why that's so meaningful to you. Would it be okay if we use this other word instead? This is why I think this might be helpful. And that can become a conversation where everyone can kind of have an open discussion. You don't have to just be like, oh, words are banned in my office, no way, no how, because that can be alienating as well. We don't want to like be like politically correct police and make people not want to come into our offices that way either.
So we do have a comment in the chat from Kimberly. She says she's excited to see the shift in language and attitude, and that when working at a treatment facility years ago, the model of the individual being the expert in their own recovery was unheard of. So it was only the way of the facility. So I think that is really positive. Thank you for that comment, Kimberly.
Yeah, for sure. And I think, yeah, I think that's a lot, but I say the providers are a big part of this problem, right? Is we're the ones who are like, I have the education, I have the training, do as I say. And we need to do a lot of the self-correction and realize that, you know, we don't know everything. We have imperfect science that we're trying to make our best guesses with, and the person really knows so much that we can learn from.
Well, if there are no other questions or comments, we'll go ahead and wrap up our session today. Thank you so much, Dr. Ginley, for being with us. And thanks to the team from ETSU and UT Extension that has helped to produce today's webinar. We are taking a break for the summer, but we hope that you'll join us for the next series, which will start this fall. You can view recordings of previous webinars and our resources on our project webpage at prompt.tennessee.edu. And thank you everyone for joining us today.